I'd like to welcome you to our webinar on controlling for random variation in shared savings programs. This is a subject that we have encountered and worked on in several projects, and so we're happy to share this with you. Next slide. Our agenda for today is first, I'll give some background on Discern, and particularly our work in the payment reform area. And then Guy will review the basics of shared savings, describe what random variation comes from in a shared savings context, the methods that we've been involved with and used in order to limit the impact of random variation on the decisions to share savings with providers, and then give you a framework for evaluating your own potential plans for your shared savings models. A few housekeeping ground rules. The presentation will last about an hour, and we've allowed 30 more minutes for questions and answers. All attendees are in listen-only mode, so we will ask you to submit questions via the webinar question function, and you should see that on your screen. We'll take questions and discuss them at the end of the presentation. And then you also have on the last slide emails for me and Guy to request a copy of the slides. So first of all, about Discern, in case you're not familiar with our work, we are a small consulting firm headquartered in Baltimore, Maryland. And we work on projects and partner with our clients for three goals: better delivery of care, better payment models, and better planning, all of which we think will contribute to a better healthcare system. So first of all, what we do in the world of delivery of care mainly concerns the patient-centered medical home and the patient-centered medical home's contribution to accountable care organizations. On the right-hand side of the slide, you'll see our depiction, our graphic depiction of the patient-centered medical home and how it works with its patients, its population up in the left-hand corner, the medical neighborhood down below, and on the right, measurements, quality measurements in particular, and incentives. And incentives are our subject today. Regarding patient-centered medical homes, we do coaching for transformation as well as for NCQA recognition and utilizing practices, electronic medical records for performance measurement. We do a lot of communication regarding what the medical home is about for all kinds of users, including employers, health plans, and companies that want to relate to that concept. We also do analysis of the medical neighborhood and how the patient-centered medical home can work within the medical neighborhood. Then regarding better payment models, which is what we're focused on today, we have a number of projects developing shared savings payment methodologies for various payers and multi-payer collaboratives. We do financial modeling and analysis, again, for payers and also for providers. And pay-for-performance models we've all been involved with for quite a long time. We also have a number of projects that look at how does all of that, how do better delivery models, better payment models fit into better planning for a variety of clients and stakeholders and organization types. And so our projects focus on choosing and using quality measures, on creating report cards for providers and report cards for the public on provider performance, collecting and managing quality data. Specifically for producers, we look at planning product strategy in this new world of the patient-centered medical home and new payment models. We do a variety of feasibility studies and case studies. So those are our major categories of work. Specifically regarding payment reform experience, as I said, we've been involved in physician pay for performance. Discern has been involved in this since 2004, and Guy D'Andrea, the founder of Discern, and I have both been involved in pay for performance longer than that. In particular, our longest-running client regarding pay for performance is the Leapfrog Group. We support their hospital pay for performance in a number of ways. We also have a 3-year project with the Maryland's multi-payer patient-centered medical home pilot, in which we have designed both the ongoing transformation PMPM patient payments as well as the shared savings methodology. And then for a health plan, we actually developed a risk-based payment model. And then we've built models and calculators for a variety of clients to figure out how different incentive systems affect them. Here is a list of our published research, most of which Guy D'Andrea has contributed to. And as a most recent one, well, there's one in pre-publication. The most recent one specifically addressed shared savings programs and was in Health Affairs in September. Our speaker today is Guy D'Andrea, a managing partner who founded the company in 2004. He's been involved in healthcare policy for 20 years and for several years been involved in the application of policy to specific clients and organizations. His major focus is payment and payment reform. He's also involved in healthcare delivery reform. Previous to starting Discern, he held leadership positions at URAC and the American Association of Health Plans. His degrees are from Columbia and the London Business School, and he's a pleasure to work with, and I will turn it over to Guy D'Andrea.
Thanks, Linda, and thanks everybody for joining us today. We'll be talking a lot about random variation today and its effect on shared savings programs. And so what I want to do is start the presentation by really defining some terms and how we want to think about random variation in a shared savings context. And so to begin, let's just review some of the shared savings, the basics of shared savings programs. We could do a whole separate webinar on some of these details, but I just want to remind everybody the way that shared savings programs typically work. So in a shared savings program, a provider organization, like a patient-centered medical home or an accountable care organization, is assigned a defined population of patients. Often those patients are attributed based on where the patient receives the majority of their primary care. And these patient assignments are typically made at the payer level, right? So if Medicare, for example, is operating a pay-for-perform or a shared savings program, then it would assign its beneficiaries to a provider organization. If a health plan is operating a similar program, then they would assign their patients to provider organizations. And because of this, it typically means that even within a provider organization who might be participating in a shared savings program with multiple payers, its population has actually been subdivided at the payer level, right? So it has its health plan A population, its health plan B population, its Medicare population. And so for that reason, we end up with smaller populations within the overall provider organization than we would have if we could group all of the patients together into a single shared savings pool. And as we'll see throughout the presentation, that's important because population size is probably the single largest driver of random variation in these programs. But the provider organization is assigned this population of patients, and then the payer, who is sponsoring the shared savings program, would calculate the actual cost of care, the total cost of care for that assigned population over a specified period, and then compare that total cost of care to a benchmark. And the methodologies for defining these benchmarks vary from one program to the next. It might be on the provider organization's historical costs. It might be based on the trends across multiple provider organizations or even across a region to determine, what the benchmark is. But basically, the payer calculates the provider organization's actual cost of care relative to a benchmark. And if the actual costs are less than the benchmark, then there are savings to be shared. Conversely, if the actual costs are higher, then you could argue that there's a loss. Whether the provider organization bears responsibility for any of that loss depends on the structure of the shared savings program. In a two-tailed risk model, the provider organization would both have an opportunity to earn rewards when there are savings and would incur some penalty if there are losses. But in many of the shared savings programs that are out there today, they use a one-tailed approach where there's only upside risk for the provider. If there's a loss, they don't bear any penalties. In Medicare's shared savings program, provider organizations have a choice between a one-tailed and a two-tailed risk model. Most of my remarks today will be focused on a one-tailed shared savings risk model, but I think you'll see throughout that you could apply similar concepts to a two-tailed model. And the goals of shared savings programs, I think by now, are well understood within the health delivery and the health policy community. A primary goal of shared savings is to drive improvements towards the triple aim of better health care, and lower costs. One reason that shared savings is a popular strategy for trying to move in that direction is that it allows a transition to a risk-based model without completely discarding fee-for-service reimbursement, right? Under most shared savings programs, healthcare payments continue as they have already been structured, and then there's a retrospective analysis of the costs that drives the shared savings calculations. So administratively, it's easier to move to shared savings when you have a fee-for-service system in place than it is to move to other more comprehensive payment reform models like episode payment or global payments.